We have to understand that doing CPR alone, that is chest compressions and assisted ventilation, is not the same as treatment of cause. When we talk about sudden cardiac arrest, we're talking about the heart stopping, preventing blood flow to the brain and perfusing the vital organs, equate cardiac arrest to heart attack, which is not the same, as we all know. We also know that giving chest compressions when the heart is stopped, it just maintains blood flow to the vital organs, but it does not sustain it. Unless you actually treat the cause, you'll be doing CPR. So this is again something which is quite well documented in literature, the so-called 5 H's and 5 T's, which should sound familiar to most, if not all of you. So these can vary depending on which guidelines you follow. Without further ado, let's get started. It's quite an interesting topic which was assigned to me, management of cardiac arrest. I do respect and appreciate that there is a wide variety of healthcare professionals here, from those who are just starting out their careers to those who are very experienced, maybe those who don't see it on a day-to-day basis, but I think it is important for everyone to at least be aware of what we can do, since it is not just in the emergency department or in the ICU or in the operation theater where cardiac arrest can happen. So this is just a picture taken from the 2020 chain of survival by the ACLS guidelines. We all know this. There have been a few additions which I've highlighted here. They have put a lot more emphasis on recognition and post-arrest resuscitation. I will not be going much into detail about the actual cardiopulmonary resuscitation. I'm sure everyone knows that to some degree. And that just makes the whole thing redundant. It's just one flow chart you can look through. It's not much to go over. We have to understand that doing CPR alone, that is chest compressions and assisted ventilation, is not the same as treatment of cause. When we talk about sudden cardiac arrest, we're talking about the heart stopping, preventing blood flow to the brain and perfusing the vital organs. But we also must look into why the heart is stopped. Many people think, well, especially lay people, when they think about cardiac arrest, they equate cardiac arrest to heart attack, which is not the same, as we all know. We also know that giving chest compressions when the heart is stopped, it just maintains blood flow to the vital organs, but it does not sustain it. Unless you actually treat the cause, you'll be doing CPR, for the entirety of your shift, if not beyond that. And if you don't treat the cause, arrests will keep happening. So that's what this talk is going to mainly be on. The recognition of some of the common causes of sudden cardiac arrest, how you can recognize it, and what we can do to fix it. We must know that while giving CPR, treatment must go hand in hand with resuscitation in order to effectively achieve ROSC and bring the patient back. Of course, during the CPR flow, for CPR guidelines, you must keep reiterating to your team about what it could be, because sometimes, in fact very often, the cause is not immediately obvious. So this is again something which is quite well documented in literature, the so-called 5 H's and 5 T's, which should sound familiar to most, if not all of you. So these can vary depending on which guidelines you follow. The ACLS from America, the ALS from UK, the Resuscitation Council from Australia, where I currently am, they have their different permutations and combinations of what these things are, but by and large, there are 5 H's and 5 T's for the common causes of cardiac arrest. We will go through each of these in detail, and hopefully by the end of it, you'll be able to at least recognize and presumptively treat certain things as they come up. So we'll talk about the 5 H's first. The first one is obvious, hypoxia. Now, any respiratory failure or respiratory arrest, and other causes as well, hypoxia. Maybe even secondary to other things, hypoxia secondary to drug overdose, hypoxia secondary to a thrombotic event. But by and large, if there is a hypoxic element, and that must be treated. Why is hypoxia a cause of cardiac arrest? Because myocytes are starved of oxygen, and myocytes are what make up the myocardium. Without oxygen, the myocytes don't function. Myocytes don't function. There is reduced oxygen to the cells. That causes anaerobic metabolism. There's reduced ATP generation, less energy produced, lactic acidosis, and as we all know, when there's lactic acidosis or metabolic acidosis, heart contractility reduces, and so on and so forth till the heart finally stops. That hypoxia can be secondary to respiratory failure, strangulation, or drowning. And well, you can see the pictures down there. A normal, healthy, perfused, pink person becomes ashen gray, cyanosed. Sometimes the lips may be red in methemoglobinemia, but we'll turn to that later. So bottom line, hypoxia, reduction of oxygen in the bloodstream. How would we treat it? We treat it by giving oxygen. So during CPR, we must remember to always bag with 100% FiO2. I have seen situations, especially junior doctors, I have done this when I was a junior doctor, is that when I'm trying to bag a patient, I forget to connect oxygen. So I just take the ambu bag and mask. Because the bag is nice and big, you think that, okay, well, it's full of air, and you just keep bagging the patient. But at the end of the day, when we are bagging an empty mask, what are we doing? We are giving room air to the patient. Room air is 21% of FiO2. That's nowhere near enough. The myocardium is starved of oxygen. We must flood it with as much dissolved oxygen as we can. So 100% of FiO2, connect it to the wall oxygen, turn it up all the way to full. We must consider early intubation and mechanical ventilation if the skills are available. If not, a second generation LMA will do. And remember, again, to treat the precipitating factor. Now, all the 5 H's and 5 T's are not mutually exclusive of each other. We have to understand that sometimes there can be an interplay, like bronchospasm or retention pneumothorax, which comes a little bit later, can cause hypoxia. So you must treat the cause while giving oxygen. After CPR, guidelines do say that you must intubate with an endotracheal tube. That is now without any controversy. And maintain saturation between 92 to 98%. Simply because when there is too much oxygen all the time, there can be damage to the rest of the body. So that's how to address the hypoxic part in cardiac arrest. The next H, hypovolemia. Less intravascular fluid or blood in this case. Why does that cause cardiac arrest? Because we know from our first year physiology, well, I didn't learn it in first year, I was too busy sleeping in class. I learned it when I was doing my emergency medicine training. When there's reduced cardiac preload, we have reduced contractility as per Starling's law. Similarly, when there's reduced cardiac output, so when there's less blood entering the heart doesn't contract well, less blood goes out. Likewise, when there is less blood to circulate, secondary to hemorrhage or hypovolemia, you have reduced tissue perfusion. Again, we go into the whole lactic acidosis cycle where there's less oxygen, there's anaerobic metabolism, so on and so forth, and the heart does not pump. Why can we get hypovolemia? Hypovolemia can be relative hypovolemia, secondary to sepsis, can be absolute hypovolemia, such as gastroenteritis or any kind of acute blood loss. Now, the picture on the lower right corner is a BP cuff showing a low systolic blood pressure. I put that up there because it's very important for us as healthcare professionals to understand hypotension is not the same as shock. Hypotension is a clinical diagnosis from your sphygmomanometer. When your systolic is less and your diastolic is less or whatever, the whole 120/80 being normal blood pressure has long since been debunked. Different people have got different blood pressures. You can have a small, thin individual with the blood pressure with a systolic of 90, and that person will be absolutely well perfused. Likewise, a blood pressure of 120 systolic will actually be shock or hypotension for an elderly person with normal systolic blood pressure high. So there are much more sensitive indicators of organ perfusion, and shock is a pathological diagnosis when the body does not get nutrients from the heart. So hypotension is a clinical diagnosis, shock is a pathological diagnosis, and they both are not interchangeable. How to treat hypovolemia specifically? We give IV or either intravenous or intraosseous fluids, 30 mils per kg being the first initial bolus, and subsequently we can up titrate as required. Early inotropes or vasopressors, especially important in sepsis. We should maintain a systolic BP of at least 90 systolic as per most guidelines, but that can vary depending on the person and the age, of course. A MAP of around 65 is acceptable in most cases of shock. Of course, in elderly or hypertensive patients, renal patients, you must target higher blood pressures, especially knowing that a BP of 110 or even 100 systolic may actually be low for them. And if you have the capacity to measure urine output, please ensure an output of at least 0.5 ml per kg per hour. Doing this will address your hypovolemic part in cardiac arrest. We're not talking about kids here, but in children, you need at least 1 ml per kg per hour of urine output. The next such is acidosis or hydrogen ion basically. Why does it cause cardiac arrest? Because as mentioned earlier, lactic acidosis, any acidotic state, whether respiratory or metabolic, causes direct myocardial depression, reduced cardiac output, reduced blood flows out, cardiac arrest. So you have respiratory acidosis, metabolic acidosis, and mixed acidosis. The examples are on the screen. And the formula to remember all this is the formula that we remember from, well, you all may remember. I remembered it much later, where it talks about the interplay between carbon dioxide, water, bicarbonate, and hydrogen ions. So each one is interchangeable. Remember to not aggressively overcorrect the respective acidosis or alkaloses with bicarbonate, because that can actually offset your balance. The treatment of metabolic acidosis is to treat the cause, treat the cause, treat the cause. There are so many instances where the minute someone recognizes metabolic acidosis, oh, let's give sodium bicarbonate immediately, because soda bicarb as a base, as an alkaline substance, should correct the acidotic substance, right? Wrong. Remember, sodium bicarbonate, as mentioned in the previous slide, if you look at sodium bicarbonate, what happens to it? The bicarbonate gets broken down into carbon dioxide and water. Now, if you're in a situation where the patient cannot exhale the carbon dioxide out, that carbon dioxide is going to stay in the system and contribute to respiratory acidosis. So unless you are absolutely sure that the patient can exhale that carbon dioxide, be very careful in giving sodium bicarbonate. There are very clear indications for that. The literature suggests severe DKA, which means pH of less than 6.9, tricyclic antidepressant toxicity, or acidosis following crush syndrome. As part of that, if you want to give sodium bicarbonate, that's fine. There are reasons for that. We won't go into it. But be very careful in giving sodium bicarbonate when there happens to be a pH of 7.2 or 7.1 or whatever. If a patient's kidneys are functioning well, they will retain bicarbonate eventually, and the bicarbonate will go up. But always treat the cause. Treating the cause is not the same as giving soda bicarb in all patients. A venous blood gas is more than sufficient to guide your treatment for correction of acidosis. You don't have to be jumping and poking the patient's radial artery or femoral artery or whatever. You can cause more damage than good. There's enough evidence out there to say that VBG is more than sufficient. In fact, in many centers, including where I work right now, arterial blood gases are out. Every single clinical scenario is treated by a VBG, not an ABG. And yes, that includes COPD. Respiratory acidosis, straightforward, there's retention of carbon dioxide. You do not give soda bicarb, obviously, for that. What you would do is ensure proper ventilation and maintain a partial carbon dioxide pressure of 35 to 45 millimeters of mercury. You would want to intubate and control ventilation in these patients to ensure that they are not retaining carbon dioxide. You could use an ABG in respiratory acidosis, but again, there's more evidence out of emergency departments to say that a VBG is just as good for management of these cases. The next H is hyperkalemia. Well, hypo or hyper, commonly it's hyper, the high potassium ions. So, though hyperkalemia is described in literature as being more than 5 milliequivalents per liter, you only get cardiac arrest at much, much higher levels when there's cardiac toxicity and ventricular fibrillation. The most common cause of hyperkalemia by far is patients who are on dialysis, renal failure patients. But any metabolic acidotic state can push the patient into hyperkalemia. The treatment is on the screen right now. Calcigluconate to prevent myocardial irregularity, salbutamol nebs, and dextrosinsulin to push the potassium from the extracellular space or intravascular space into the intracellular space, and if required, you may need to give dialysis as well. There is really not much role in cardiac arrest situations for giving resonium to kind of excrete potassium out. That takes too long to act. But in a peri-arrest or cardiac arrest situation, which is what we're dealing with now, that should go hand in hand with your resuscitation efforts as you are treating the cardiac arrest. Similarly, hypokalemia as part of the the H, hypo and hyperkalemia. Again, textbooks describe it as a 3 MEQ per DL. Arrest typically happens at much lower rates and they're quite rare, usually from gastroenteritis, diuretic salbutamol use. DKA, funnily enough, can have hypokalemia as well. You just replace potassium. At least 4.5 grams in normal saline, which is about 60 MEQ per liter. You can give it through a central line rapidly, but most often you would not have a central line in place. You can give it slow IV through the peripheral line. The last H, the fifth H, is hypothermia, something which is not often encountered in India because our ambient temperatures are much higher. But in victims of drowning or people who have been outside for too long or alcoholics, actually in the Western world, the most common cause of hypothermia is actually alcoholism. Because they drink, they vasodilate, they spend the night drunk outside, they lose all their body heat because they vasodilated, they get brought in with hypothermia. So that can happen in India as well, especially up in the north. It's defined as a core temperature of less than 35 degrees Celsius as per Tintinelli, our standard textbook. But hypothermic arrests are commonly seen below 28 degrees core temperature, and that is severe hypothermia. Hypothermia, by multiple reasons, can cause cardiac arrest. What happens is it actually complicates cardiac arrest in the sense that the electricity through your heart after a shock is not as effective. Drugs, when they're given, they don't operate when the blood is below a certain temperature. We don't think about this, but most of the pharmacological actions in our body only happen when our body temperature is between 35, 37 degrees. So when that is less, the drugs don't act as well. So you do need to consider, you have to do rewarming if the core temperature is low and they're in cardiac arrest. And hypothermia is one situation where prolonged CPR, which is 45 minutes, 1 hour, 2 hours, even 3 hours, has been shown to be beneficial. That's one rare situation. In most cases, we would not go on for beyond a certain period of time, but hypothermia is one situation where you can advocate for prolonged CPR, especially if there's a chance of survival. The easy way to pick it up is, of course, a rectal thermometer with a core temp of less than 28. On the ECG, you've got certain waves, positive deflections just before your S wave called Osborn waves, and that's the picture of the green goblin there. Spider-Man fans will know Harry Osborn is the green goblin. So if anyone asks you in your test what's the name of the little wave in hypothermia, just remember the green goblin, Osborn's waves, so they're called. You must do aggressive rewarming during CPR. There's IV fluid warmers. If you've got inline warmer, well and good. Or heating blankets like the Bear Hugger, those can work as well. And just note that there are some caveats for defibrillation and drug administration. Defibrillation, you would shock the patient 3 times, and if that doesn't work, stop until the core temp is above 30 degrees Celsius because it's not going to be effective beyond that. Drugs, again, unless and until the body temp is above 30 degrees Celsius, your drugs, adrenaline, amiodarone, are not effective. So heat the patient, keep giving CPR, keep giving warm fluids. Once the body temperature goes up, you can start giving drugs at double the frequency dose. So instead of 1 every 4 minutes, you would give 1 every 8 to 10 minutes. So all this is there online, just something for you to keep in mind as you're doing it. So those are the 5 H's. We're going to quickly run through the 5 T's now. I know it's quite late for you all there, and I hate to take such a heavy topic so late at night, but we'll get through it quickly. Let's talk about tension pneumothorax, something very dramatic, something all of us, we both love and hate to see it. We love to see it because we're like, ooh, there's something to do, but we hate to see it because it's very bad for the patient. Why does tension pneumothorax cause cardiac arrest? It's simple, obstructive shock. You've got increased intrathoracic pressure, your preload comes down, blood does not come back to the heart, as mentioned earlier, Starling's principle kicks into effect, there's less cardiac output, dead. And there's also impaired oxygenation from the pulmonary standpoint because you have one lung which is not oxygenating. So you've got tension pneumothorax causing 2 pathologies, cardiovascular because the heart doesn't pump, and respiratory because one or 2 lungs can be blown. There can also be mediastinal kinking and shifting. So actually the second lung, which is non-affected, can get squished up, and that also may not function as well. Commonly seen in blunt chest trauma with rib fractures, can happen in COPD patients where one bullae spontaneously ruptures, and intubated patients can also have it. So remember, after intubating a patient, if they suddenly desaturate, think about tension pneumothorax in those patients. How do you treat it? Very simple. Finger thoracostomy followed by a chest tube. The hows and whys of which we can discuss at the end of this talk if we have time. The next T is coronary thrombosis. In other words, it's a myocardial infarction. You've got thrombosis, which can be several types. So coronary thrombosis in MI, diagnosed by an ECG. How does it cause it? It's pretty simple. Coronary occlusion. Coronary occlusion causes myocardial starvation of hemoglobin and oxygen. Myocytes get starved. Heart muscle doesn't function. Cardiac arrest. It's also important to note that not all MIs are from a thrombus. Sometimes, well, in fact, more common than we think, you can have a heart attack not from a blockage in the coronary, but from the coronary just not getting any blood. So when does the coronary not get blood? When there's anemia, when there is severe hemorrhage or severe hypovolemia, the heart is not perfused. That can also get starved as well. Those are called type 2 MIs. Or around an operation time or coming out of an operation when the anesthetics haven't fully worn off and the patient has severe pain causing a coronary spasm, that can also have an MI as well. So remember, not all MIs are because of a thrombus, and not all MIs need to be stented. You have to be very careful about that. The treatment for occlusive MIs is immediate PCI. As you can see, a stent going to the coronaries, and if it's a type 2 MI, you think about treating the cause. Give fluids, give vasopressors, improve coronary perfusion. That will improve myocardial perfusion. Heart pumps better. The next thrombosis is pulmonary thrombosis. So you've got your coronary thrombosis and then you've got your pulmonary thrombosis. Pulmonary thrombosis is less common than myocardial thrombosis, but it's much more dramatic. That's a pulmonary embolism. The diagnosis that every ED physician and critical care physician loves to make, but more often than not, we don't get it because it's very difficult to diagnose. How does that cause cardiac arrest? It's simply called a VQ mismatch, where you've got reduced cardiac output because there's not enough lung perfusion. That causes hypoxia, and that causes cardiac arrest. So those are commonly seen in post-op patients, patients with cancer, pregnant patients especially, and patients taking tablets such as contraceptive pills or other things which can actually cause thrombotic events in the legs. The treatment is thrombolysis or IV thrombolysis, or even sometimes a surgical thrombectomy in very severe cases. So the doses for thrombolysis are there on the screen. There are three main drugs that we use: alteplase, reteplase, tenecteplase. Alteplase is the only FDA-approved one, although there is more and more evidence coming out for tenecteplase now, and in most centers, tenecteplase is what is used, because alteplase needs a 1-hour infusion, and tenecteplase is just a one-shot and it cures. So tenecteplase is now the drug of choice, although technically not approved by FDA yet, but they're working on it. The fourth T is toxins. Toxins, especially in our country, mainly agrochemicals, plant toxins, sometimes animal toxins, snake bite, scorpion sting. So the pathophysiology depends on the toxin. Snake bites usually have a respiratory arrest part. If it's a cobra, it's a respiratory. It's a neurological paralysis, and a scorpion sting, it's a catecholamine storm, which can cause myocardial dysfunction and coronary spasm. For agrochemicals, again, mostly alkalotic states, hypoxic arrest, etc. So it depends on the toxin, really. So what we have commonly are organophosphonates outside. Over-the-counter drugs like tricyclic antidepressants, amitriptyline can often cause it, and sometimes we get opioids as well. The opioid epidemic is not as bad in India as it is in the Western world because it's not as freely available, but that may change, who knows. But in the Western world, by and large, opioids are a very common cause of toxin-induced cardiac arrest. The treatment, if they come to the hospital in time, typically within 1 hour, you can try a gastric lavage with activated charcoal after ROSC, simply because you don't want to be giving the patient other things while CPR is ongoing. That's the most important part. But after ROSC, or at least after the airway is secured, you can give gastric lavage with the IV antidote if it's available. Always secure the airway if you're trying a gastric lavage while you're doing CPR. So these are just some common toxins with their antidotes at the site. I've not gone into doses and management because that's a whole other, well, each one can have its own talk. So in short, organophosphates, antidotes atropine. If it's TCAs, your antidote here, your specific antidote is sodium bicarbonate. So you can and should give it judiciously here. If it's an opioid like morphine or fentanyl, the antidote is naloxone. If it's a benzodiazepine, because over-the-counter benzodiazepines in India are available. Alprazolam is an over-the-counter drug. Some people may take it and overdose on that. flumazenil is your antidote. The last T is cardiac tamponade, a relatively rare cause of cardiac arrest, but when picked up and when treated, we get fantastic results with it. How does it cause cardiac arrest? It's simple. When you have the heart which is squeezed between the pericardium and an ever-expanding pocket of fluid, usually blood or sometimes even just a malignant effusion, the heart, the LV size shrinks more and more and more. So that causes decreased cardiac output, decreased myocardial filling, obstructive shock, death. Commonly seen in blunt chest trauma, but often we get pericardial effusions which are slow growing, like from TB, viral myocarditis, pericarditis, etc. I have seen 4 cases where patients have had a malignant pleural malignancy or a hilar malignancy, and that has spilled over into the myocardium and caused cardiac tamponade. So you can get cases from everything, so be watchful for it. Diagnosing it is clinically by Beck's triad, which is hypovolemia, muffled heart sounds, and distended neck pains. But in today's day and age, where we do have ultrasound available in the ED, I would recommend you to place an ultrasound probe on the patient's chest and see if you can see fluid around the heart, like there in the picture. Beck's triad sounds very good to say in your seniors asking you, but how many of you, I'm talking to my colleagues in the emergency department, when there's chaos in the ED, when there are monitors going off everywhere, when you've got a million things to do, let's be honest, you're not going to be hearing muffled heart sounds on a patient's chest. You're lucky to hear any heart sounds at all, even on a normal patient. So do not rely on Beck's triad. And remember, Beck's triad can present in a left-sided tension pneumothorax as well. When there's a pneumothorax on the left side, you will have decreased heart sounds, you will have hypotension, and you will have dyssynergy JVP as well. So be very careful. Don't go sticking the needle in the wrong place for either. The treatment is pericardiocentesis. It's very simple. Needle on syringe down to the subxiphoid zone towards the left shoulder. Go in very slowly under monitoring, preferably under ultrasound guidance, and you can drain the fluid as you go. The good thing with this is even removing a small amount of fluid, 10 to 20 ml, sometimes even 10 ml, will have a massive improvement in the patient's cardiac output, and sometimes that's all they need to come back. But be very careful. This is not a procedure taken lightly. There are a lot of risks for this. Of course, the most obvious being you can damage the great vessels, the aorta, the IVC below that. You can puncture the myocardium directly. Of course, you can cause ventricular rupture. You can penetrate the stomach. There are all kinds of things there. So be very careful. Do it under guidance and follow your hospital protocols for whatever you need to for these sorts of patients. So those are the 5 H's and 5 T's. How do we put all that together when there's a cardiac arrest going? It is extremely easy to sit here and talk about, oh, do this, oh, do that, oh, check this, oh, check that, like it's no big deal. But I, and like many of you out there, know that in the real cardiac arrest situation, there is way too much going on for one person to kind of put all this together. That's why we have a team, and that's why as part of the cardiac arrest protocols, we bounce ideas off each other. The whole closed loop communication, everything comes into play. I would say that when you're evaluating a patient peri-arrest, that is just before arrest, during and after arrest, there are 4 main modalities that you should use to have a comprehensive assessment. A VBG, oxygen saturation, an ECG, of course, and if available, the point of care ultrasound, which, let's be honest, most of us here have access to, well, should have access to. And the reasoning for that is up on the screen here. Your saturation probe will tell you hypoxia or retention pneumothorax. Your ultrasound will tell you hypovolemia if the IVC is flat or if the pericardium is distended. You have a pulmonary thrombosis because of RA artery dilatation. You have pericardial effusion from a tamponade. Focus can tell you. Your venous blood gas looks at hydrogen ions, hyper and hypokalemia, and many toxins will have an acidosis as well, so VBG is part of it. And lastly, the ECG to pick up hypothermia if you don't have a core temperature, and obviously the coronary thrombosis. So you notice all your 10 modalities, all your 5 H's and 5 T's can be picked up with just these 4 modalities. Even if you don't have the POCUS, sometimes the history is clear. Like if someone's come in with a trauma, you're not going to think to yourself, oh, maybe it's hypovolemia. So you do have to kind of pick and choose your battles here and try not to focus too much on, oh, we don't have an ABG, oh, we can't treat this patient. No, when you know that the patient may have a something, you can treat without having to wait for that. But these 4 modalities can give you a comprehensive assessment of all 5 things. You do not need lab investigations. So don't be sending off lab tests. Oh, I want serum paracetamol levels. Oh, I want to have this done in the lab. No, these things are more than sufficient. One thing which is interesting is there's something called the forgotten H, which is hypoglycemia. ACLS 2005, which is how many years ago? 20 years ago, it had this as one of the H's and has subsequently been taken off. I think because most people check sugars right at triage, so we don't really miss it per se, but it can still present as cardiac arrest. So keep that in mind and keep sugars also, at least a capillary glucose, finger stick glucose, as part of your assessment if you must suspect it. The treatment is straightforward, 50% dextrose, 50 ml IV push. That should increase the sugars by 200 mg per deciliter. And how does it cause it? Well, tachyarrhythmia from a sympathetic surge. When there's hypoglycemia, adrenaline is secreted, that can cause tachyarrhythmias, probable cardiac arrest. So don't forget hypoglycemia as well. So in conclusion, we must remember that a cardiac arrest is like a raging fire. And at the end of the day, CPR, however good it is, you're just trying to put out the fire with a glass of water. Because whatever's happening in the patient, whatever fire is happening in the patient is still raging. Yes, you're getting the heart to beat again, but if you've not fixed the cause, it's just going to flare up again. So don't be just throwing water at the fire, trying to put it out. Stomp on the fire. Effectively stomp on the fire, cover it with sand, do whatever you need to, but quell the flames at the source. Don't just throw water on it from the outside and expect things to get better. Most often, they won't. But as you've seen from this talk, and hopefully what you picked up from it, is that most causes can be picked up with a little bit of common sense, with a little bit of sharing of ideas, an idea of how the patient came in, and just some basic bedside modalities that do not require fancy equipment or fancy training. In conclusion, good CPR and treating the cause goes hand in hand. They're like a happily married couple. One cannot exist without the other. You must treat the cause, manage your arrest, instead of just treating the arrest, if that makes sense. Do call for expert help when needed and when available. Anesthetics to intubate if you're not good enough. If you need more hands to manage a patient on cardiac arrest, please do. It helps you get more ideas to pick each other's brains off. Monitor post-arrest. In the new ACLS guidelines, post-arrest care is a separate link on the chain of survival. Monitoring post-arrest is very important because things can go wrong even after ROSC. Follow the chain of survival and you won't go wrong. Thank you. That's my time.
Thank you for that wonderful talk. We do have some doubts coming from doctors, and we will be getting into. So, taking one of the earlier questions from Dr. Kulkarni, is there any role of IAB?
IABP, I'm assuming you mean intra-aortic balloon pump, Dr. Ravindra. So IABP in cardiogenic, IABP, the balloon, you're talking about intra-arterial blood pressure or intra-aortic balloon pump? Because they both are IABP and... sorry, for those who
Sir, if you could clarify in the comments.
Is it intra-arterial blood pressure or intra-aortic balloon pump? They're two different things. If that can be clarified, I can talk a little bit on either, but I need a clarification on that, please. Perhaps we can take the next few questions while Dr. Ravindra replies. Normal values of EBG. Dr. Abhijit, off the top of my head, I don't think it's feasible to list every normal value. The good news is most blood gases, if not all, actually have the normal values at the site. So especially when it comes to electrolytes, whether it's milligrams per deciliter, millimoles per liter, calcium, ionized calcium versus non-ionized calcium, it can differ from make to make. Most of the normal values are actually on the side, and they can vary from place to place. So I would recommend whoever's doing the blood gases to look at the values on the side and judge accordingly. if that makes any sense, because I don't want to be saying one value. I have worked in labs where normal value pH for example, 7.3 to 7.4, 7.35 to 7.45. So it really varies between the labs. So it shouldn't really matter, even whether it's 7.3 or 7.35, that's not going to cause cardiac arrest. So your values are going to be 7 and below to cause cardiac arrest. So my advice would be just follow the values of the site and treat the patient, don't treat numbers. That's the most important thing. I worked in a cardiac anesthetic unit where after arrest in the cardiac ICU, because they gave so much sodium bicarbonate, so much everything, the patient had died post-op, but his ABG was absolutely normal because they just corrected all the numbers but didn't fix the cause. So VBG should guide your therapy. It should not be an endpoint to what you're trying to get. That's the most important thing.
So taking the next question from Dr. Naveen. So severe gastric can cause MI. Is it possible?
Well, gastric, I am assuming you mean gastroenteritis, Dr. Naveen, because in which case, yes, it can cause, for two reasons I can think about. One, severe gastroenteritis can cause hypovolemic shock, cardiac arrest. We've seen that in cholera or very bad viral gastroenteritis. And severe gastro can also cause hypokalemia, which is an established cause of cardiac arrest. Usually it's treated on time. I'm not saying it's a common thing, especially now with healthcare being more easily available, we can treat it. But if your question is if it can cause cardiac arrest, then yes. Gastric can cause MI. If you're specifically asking myocardial infarction, it's very, very rare, but theoretically, yes. When you do have hypovolemia, your coronaries are starved of blood, so you can have a type 2 MI from gastroenteritis, but it's rare. It doesn't usually happen. More often than not, it's just hypovolemic shock which causes cardiac arrest a little bit later. And you would not thrombolize this MI. You would just hydrate the patient, rehydrate them, fill up the capillaries, and they're good.
So, next, Dr. Ashwini asks, cardiac arrest predominate in younger group, health conscious even after COVID and gym participants. So what to do?
Dr. Ashwini, thank you for the question. It is a troubling trend to see that yes, cardiac arrests are actually happening in younger age groups. With regards to what to do, I think that's beyond my scope to give a definite answer. What I can say is, after the whole COVID debacle a few years ago, there were some high-profile issues where young cardiac arrests did happen. All I can say is educate your neighbors, educate the public. Tell them that a heart attack is not the same as MI, and things like stress could be compounding it, factors like diet could be compounding it, people aren't getting enough exercise. So I would say just have a much bigger conversation with your public, with your friends and family, and with their friends and family. Make them aware now that death is no longer the domain of elderly or sick people. You can have healthy people collapsing on the street from different causes. So just be aware and take care of your health. Each one knows what their healthy lifestyle or ideal lifestyle is. So take care of your health, and then you should hopefully bring it down. At this time of the night, at this part of the lecture, that's all I can really talk about. But that's a complicated topic and one that definitely warrants a broader discussion with everyone else. Take care of yourselves, tell your loved ones to take care of themselves, and spread the message. That's all I can say. 5HT phenomena in sudden cardiac arrest episode. How to tackle these to prevent sudden cardiac arrest? Well, you tackle it in the ways that were shown in the talk. But if what you mean is how to prepare for it, I guess that would just mean when a patient presents to you, when the doors fly open and then a patient is brought in saying, patient has no pulse, start your CPR, do what's needed, follow the BLS and ACLS algorithms, and have one person try and talk to whoever brought the patient, whether it's a paramedic, whether it's a family member, whoever, and try and get some clues. Were they in an accident? Did they have any chest pain before they collapsed? Uh, were they taking any medications? Were they found on the floor with some bottles of pills next to them? That will help you guide your therapy to go forward. As to how to tackle these, we've spoken about this. I hope that this lecture is recorded, that we can go back later and have a look at the different ways to tackle it going forward. But yes, it is a challenge, especially when we don't have any details, and often we don't. But sometimes once we speak to someone who knows what's going on, you can correct it, while your CPR is going on. So one person has to be delegated to go and get those details from whoever brought the patient. That's very important. And ask your team, ask your colleagues around you, what could this be? Usually you'll get the answer. Yeah.
Moving on to the next question. It is from Dr. Sundaram, aortic dissection in cardiac arrest.
Okay. So thank you, Dr. Ashok. Aortic dissection in cardiac arrest, yes, it is a cause of cardiac arrest. If you want to specifically ask what H1T it falls under, it would be coronary thrombosis, because your aortic dissection, it can be either hypovolemia or coronary thrombosis. So if an aortic dissection splits your vessels down, you can have a rupture into the intimal rupture and have a bleed from there, or it can go all the way up into your coronaries, dissect the coronaries, and cause a type 2 MI over there. Again, you would not thrombolize that. How to manage it? Very complicated. Aortic dissection is one of those conditions where, whichever part of the world you're in, if you have it, or rather if somebody comes with it, unless everyone is absolutely on board, you've got a vascular surgeon, thoracic surgeon, or an extremely good general surgeon, a good operation theater thing. Because the problem with aortic dissection is, and this is data gleaned from textbooks, from the onset of symptoms, every hour you don't get treated, you increase your mortality by 1%. By theory, that means if you're 1 to 5%. So if you don't get treated within the first 6 or 7 hours of having an aortic dissection, you are basically 50% or 60% chance going to die anyway. That's one of those very, we still haven't figured out how to treat that appropriately. Pulmonary embolisms, thankfully, now are treated and picked up much more easier, but the dissection remains to be difficult. So you could use the ultrasound at this point. When you are using the ultrasound, if you do pick up an aortic dissection when you're checking the heart or scanning downwards, and you pick it up, then hopefully you could alert your surgeons and whoever else, the blood bank, whatever. But aortic dissection presenting with cardiac arrest, it's very difficult to salvage those patients, simply because even when you do get a pulse back, that patient has to have a pulse and make it to theater, which often doesn't happen. Difficult question, extreme difficult scenario. But if the question in the context of this talk is, can it cause cardiac arrest? The answer is yes. And the pathology is coronary thrombosis, well, a coronary event, and hypovolemia with acidosis. That would be the clinical cycle here.
So Dr. Naveen asks, young age MI is common nowadays. Which all investigations to identify?
It would be the same as the others, I imagine. Uh, the problem with young MIs, and yes, there are plenty. I think the youngest MI I have seen personally was an 18-year-old boy who sadly didn't survive. The problem with young MIs is, when they have a block of a major vessel, young hearts don't have tributaries or collateral arteries to supply the rest of it. Elderly patients, as they get older, due to degenerative changes, when atherosclerotic plaques form in the coronaries, there are vessels which split off and try to supply the rest of it as bypass channels. Young hearts don't have that. So, one major block can cause sudden, rapid deterioration and goes on. How to identify it? The same as you would any MI. If you have a young chap coming in with typical chest pain lasting for about 6 or 7 hours, you would send troponins, maybe CKMB if you have it, an ECG to pick up ST elevations is the same. If your question is how to identify it before they happen, um, I really don't have an answer for that, simply because if somebody is not symptomatic, they are not going to have elevation of cardiac enzymes. There is some evidence now to show that our Indian population, most of whom don't eat meat, B12 deficient and homocysteine, they have much higher levels of homocysteinuria, which has been linked to cardiac thrombosis. But I'm not an expert on that. I've just seen it coming up in journals now and then. So difficult to identify before it happens, but when it does happen, if you do suspect it, investigate it as you would investigate for any case of MI, regardless of age. So yeah, that would be my answer to that. Thank you, Dr. Nathan, for the question.
Go back to Dr. Kulkarni's question. Sir means intra-aortic balloon pump. So I'm just highlighting Sir's
Oh,
question.
sure. Intra-aortic balloon pump. That is not a that is a term I have not heard in how many years has it been now? 6 or 7 years. Not since my anesthesia post graduation, I've not heard of it. Uh, but intra-aortic balloon pump, you will never find an intra-aortic balloon pump. At least to my knowledge, you will never find that device outside the cardiac theater ICU. Um, Maybe I'm wrong. Maybe there are some EDs in the country that place intra-aortic balloon pumps in the ED. I don't think so. To just to educate those of us around, the IABP or intra balloon pump is a device used in the cardiac ICU to maintain perfusion in a failing heart. It's something which takes quite a bit of skill and time to place. After ROSC, the if the diagnosis has been confirmed to be heart failure or left heart failure or something, maybe you could try placing it. But I don't think routine IABP use for the purpose of this talk is going to be beneficial to our patients, because most people have not heard of it or seen it. I could be wrong. If I am wrong, someone please point me out here. But to my understanding, it's not a device or procedure which is done in the ED specifically. And there are risks as well. For example, if there is someone mentioned about an aortic dissection a few questions ago, an aortic dissection is an absolute contraindication, even if suspected aortic dissection, an absolute contraindication to place an IBP. So unless you're absolutely sure of the diagnosis, which in most cases you won't be, I would not advocate for IABP in cardiogenic shock. Perhaps one of our cardiology team or thoracic surgery team as part of Medflix can take a session on IABP, but it's a very, very specialized piece of equipment, and it would really not be applicable to, I would say, most, if not 90% of the people listening to this talk. So thank you, Dr. Ravindra, for the question. I don't think it's really appropriate to talk about as a general thing for this kind of crowd, because it's very, very specialized. We could talk about ECMO, we can talk about all kinds of things, but IBP and cardiac shock in this particular subset, not really appropriate. And we're talking about cardiac arrest here, not cardiogenic shock per se.
Right. So next question is from Dr. Gulong. Sudden arrests in family history, how to go about evaluation in the rest of the family?
So these people would need a full workup. Again, none of these are predictors that you can have a cardiac arrest. Yes, there are certain clues. Sudden cardiac death in the family is a strong predictor, but there's no way to say when someone's going to die. You can have the million comorbidities and you can live to a ripe old age. You can be absolutely healthy and you can drop dead when you're 20 in the gym, as we saw earlier. But the history of sudden cardiac death is very important. As part of screening, I'm not sure if any blood tests pointed out, but I do know that in screening there are a few ECG signs you can look out for, like a coved T wave, long QT syndrome. These things are there. Again, those are not really treating cardiac arrest. We have a history of sudden cardiac death. Screening of those require a cardiologist or a very specialized physician to look through. And again, all you can do is give them, yeah, you can tell, yeah, you have these features, you are at risk. Be careful. That's it. What you could do is tell them if you get chest pain, if you feel short of breath, go to the hospital immediately and get treated. But yeah, safety net them, ask them to go to the hospital if they feel unwell, but do tell them that you had this. It's like saying if someone's relative had cancer, there's a chance that that cancer can get transmitted down as well. So screening for those requires the specialized person to look at them. Again, not really part of the scope of this talk. Here we are just talking about managing cardiac arrest, and I think we should stay focused onto that because, firstly, I'm not an expert at screening the general public, and secondly, screening the public is not the same as treating them. You will treat them whether or not they have risk factors for it. So it would just be if you have to educate them, but treat them as you would treat any other patient coming in, regardless of the family history. Because at the end of the day, family history doesn't matter. They're still going to have a problem. You're still going to treat them, right? Yeah.
So there was another question from Dr. Gulam. Is CT score the better predictor of MI or CT angio?
To be very honest, Dr. Gulam, I don't know the answer to this. I'm not familiar with the CT score as a predictor of MI, so unfortunately, I can't answer it. Again, if I didn't prepare for the question because that was not part of my talk. I will look it up. It sounds interesting. It's something that I personally never come across, but I really do not know the answer to it. I do notice that a lot of the questions here, reasonably so, are geared towards predicting cardiac arrest. How do we know when arrest is going to happen? Which, yeah, in a perfect world, as doctors, we should be able to know. But I personally don't think we should be going into things like CT scores or fancy invasive investigations for our patients to predict certain things because, as we have pointed out earlier, young healthy individuals are having heart attacks. Our young individuals are dropping dead of cardiac arrest. A person who has no risk factors at all can overdose on something and be brought in dead. A person who is healthy, young, fit can have a road traffic accident and come with hypovolemic shock. Whatever the many etiologies of cardiac arrest are, they all boil down to the same 10 pathologies. And we cannot treat etiology. As doctors, we treat pathology. And if the pathology is MI, which is coronary thrombosis, then CT score or CT angio is not going to make a difference. You're still going to activate the cath lab if it's a STEMI, open the vessel, and then the cardiologist will manage the rest after that. So in the ED or in the ICU or in the theater or even in the wards, we must remain focused on managing the 5Hs and 5Ts, investigating it appropriately, and then thinking about what to do later. Because at the end of the day, none of this matters if the patient doesn't have a pulse at the end of your resuscitation. You're not going to think, oh, I should have done a CT angio, oh, I should have done a CT score, or whatever. What you're going to go home sad about is I couldn't save the patient. So I think we should not get carried away with investigations and management and predictors and stuff because when someone comes to you in cardiac arrest, none of that matters. What matters is how you identify it, your skill in resuscitation, your targeted, focused attempt at fixing the cause, and your post resuscitation care. Those are what really matters, and that is the length and breadth of this talk. But I will look up the CT score because I've never heard of it, and it's good for me to learn something new as well. So thank you for that, Dr. Gulam.
So could we take the last two questions
Yeah,
from the comment section? Yeah.
I'm fine if the audience is fine. I don't have a problem.
Next, Dr. Krishna Priya. No chest pain, breathlessness, no lung sounds leading to cardiac arrest. How do we manage?
So there's no chest pain and there's breathlessness on the lung sounds. So is the breathlessness bilaterally? In my mind, when I'm thinking about this case, I've got three things. One is severe, no breath sounds. So you've got a severe asthmatic who's in very bad bronchospasm and air is entering the chest. The second thing is probably a smoker, COPD patient who has blown their lungs, got a tension pneumothorax, absent breath sounds, cardiac arrest. How to manage? Clinical skills, quick patient history. If you have an ultrasound, very useful because an ultrasound can tell you if it's a tamponade or if it's a pneumothorax or whatever. So you need to use ultrasound then. Others, even if you don't have the ultrasound, if you're thinking of tension pneumothorax, look at the trachea. If it's shifted to one side, probably a tension pneumothorax. And even if you're not, don't have a diagnosis, just stick a needle inside. What's the worst that can happen? You stick a needle in the chest. If air comes out, you've treated the tension pneumothorax and you've diagnosed it. If air doesn't come out, think of something else. Give salbutamol. Give adrenaline. Adrenaline nebs can widen the bronchospasm. So treat the disease, whatever you think it is. But if you've done the needful and placed your needle, when do you have a cardiac arrest, no breath sounds? Usually a tension pneumothorax. Treat that and move on with your therapy. All resuscitation protocols, whether it's in trauma, whether it's in cardiac arrest, they don't say do an intervention and then wait. Waiting is the worst part. Do an intervention and keep moving through. There are a million other things you can be doing. Remember, you got to get your lines, you got to get fluids on, you got to give oxygen, you got to intubate, you got to what else going on? Fix the problem and keep moving. You may not hit the bullet at one shot, but you can have a machine gun fired, everything, and try one of those to hit something, right? So never sit and wait. It's something I've also struggled with when I was training. I would do something and then I would wait for something to happen. Remember, if you're giving a drug, if you're giving an antidote, if you're giving anything in the patient's veins, that has to go through the veins, into the IVC, to the heart, to the lungs, back to the heart, to the left ventricle, and then circulate through the body. That doesn't work if you're not giving the heart compressions. So don't give the patient an antidote and then wait. Your CPR has to continue. Only then the treatment can circulate through the body. That makes sense. In this case, you punctured the lung. If it's a tension pneumo, well and good. Keep going. If it's not a tension pneumothorax, then ask around. What else could it be? What else could it be? So it really depends on the clinical scenario. But in the scenario you've given me, I would say three things: either an asthma, a severe asthmatic with bronchospasm, COPD, or probably a tension pneumothorax as well. That's what I would think.
So taking the last question from Dr. Mishra. What is the duration of CPR in cardiac arrest?
Oh my goodness. I was actually expecting this question to come much earlier. I have to finish with this question. Whenever I give a talk on cardiac arrest, this question always comes up. Unfortunately, there is no right answer to this question. And simply because different etiologies in cardiac arrest have different times of survival depending on where you work. I'll be very frank, in our country, one of the leading causes of arrest are trauma. We know that our emergency medicine systems or pre hospital systems are not the best as compared to the rest of the world. So we don't, so when the patient reaches us, the hospital, most patients, they are too far gone in the field to resuscitate adequately. Likewise, if you spend all your time resuscitating a patient, remember if your post resuscitation care systems are not established, they may have a pulse going, but they're going to be mentally shut down. And I mentioned earlier about toxins and hypothermia being good indications for prolonged CPR. That's because hypothermia is actually neuroprotective. So even though they have shut down, the brain is still well protected, so you can reperfuse the brain well. It really depends on the ethical standpoint of your hospital and the protocols that your hospital follows. Many hospitals have got different protocols. I don't want to say which is right and which is wrong, simply because there's really no evidence to back up what is an effective time of CPR. Most hospitals do agree that if you don't get a pulse within 15 to 20 minutes of CPR, then it is unlikely that the patient will have good brain function if they recover. But I say that in a very guarded way because I know that there are people from different hospitals listening in. And I don't want them to think what's right, what's wrong. My advice would be if there is such a situation, and I'm glad you brought this up because this is a situation that a lot of doctors, especially junior doctors on their night shift, suffer with. Because when they get presented with a patient who's like that, and they keep going and there's no apparent benefit, the question always comes into people's mind: what's the point in continuing? Is there a point in continuing? If I continue, what's going to happen? My advice would be talk to your administrators, talk to your department heads, and see what they feel, and stick to that, because there is really no evidence base to what is an effective thing for CPR, because arrests have different reasons, arrests have different pathologies, different hospitals have different means to meet those pathologies. Some hospitals may not have cath labs to open up a block stent. Some hospitals do not have 24/7 surgical cover to take a patient to theater. So it really depends a lot. I think 15 to 20 minutes by and large is a reasonable time, because remember, you can't be spending all your efforts on a patient that can't be salvaged. But do talk to your administrators and department heads. That though they're probably the best people who can answer the question rather than me. But I worked in several different hospitals. Each of the hospitals had different cutoffs for when we would stop CPR. But yeah, it really depends on the institute and their protocols. It's not something which I can answer, because it's a question nobody has an answer for. So that has to be decided by your hospital leaders, not me, unfortunately. A good question, a sensitive question, a pertinent, relevant question, but unfortunately, there is no correct answer that I can give you. It'll have to be from your superiors, not me. But thank you, Dr. Binod, for closing with that very relevant question. Yes.
So I think with that, we covered all the questions from our doctors. Um, Thank you so much for very patiently taking in all the doubts that was coming in from our doctors. And I would like to thank you once
No,
again for this wonderful session, sir. It was really lovely having
thank
you
you.
back and really hoping to see more of you.
Yeah, I'm hoping to be back too. Luckily today it worked out. I'm still in my scrubs, as you can see. I literally
Mm.
I just got back from work, and it's now 2 o'clock in the morning for me. But I'm happy to take more sessions like this. Um, at the outset, before we close, thank you to the audience for your patient listening. I do know there was a lot to cover. I know that a lot of you have burning questions which I was not able to answer, simply because they were out of the scope of this talk, and because they are questions that I can't answer myself. I apologize for that. I hope this doesn't affect my rating too badly, because I usually do have answers for most of the questions. But these questions should be asked to your superiors and to your colleagues, because they are very institute specific, very situation specific, and mine was just a general overview. So please do take this up to your superiors whenever you need to, and hopefully you all can make a difference where you work in case this comes to you again. The 5X and 5Ts, you address those, and you often will give the patient the best chance. Am I going to say that your patient is going to be saved all the time? No. The survivability of out of hospital cardiac arrest is only 10%, and in hospital arrest is only 20%, despite best efforts. But you can give your patient their best chance if you go through it in a systematic way, which is what I've hopefully showed you here. So, good night, everyone. Thank you for your patient listening, and thank you, Basha, for having me on here. It was a pleasure to be back on. Good night, everyone.
Thank you. Thank you so much, sir. Bye bye.